Ragam, Chaitanya, Lahari. Mystery in the muscle. Okay. Vicky Agarwal. And Ruju is also there. So we have all next. So let's be very particular with the time.
Good morning all. I am here to present a case, mystery in the muscle, unveiling a rare case of orbital myxoma. 42-year-old female presented with a forward and outward deviation in the left eye since 2 years with restricted eyeball movements. Insidious onset gradually progressing, associated with redness, watering, headache since 2 months. There are no aggravating and relieving factors, no diurnal variations and not associated with pain. There is no history of any previous ocular or facial trauma. It is known hypertensive since 2 months on regular medications and no other systemic comorbidities. No history of previous ocular surgeries. Earlier diagnosed with a pseudotumor of the left orbit and treated with the oral prednisolone and methotrexate by her local ophthalmologist for a period of 8 months. There is nil significant personal history, general examination well built and nourished, systemic examinations normal findings. Coming to ocular examination, on inspection no compensatory head posture seen, facial symmetry is maintained, ocular symmetry is lost, no visible pulsations or engorged wings, lid retraction is present, lid lag is present and lag of almost of 2 mm is present. There is inferior scleral show and there is no change in proptosis on Valsalva. Coming to anterior segment examination, right eye vision 6/60 with -4.50 diopters improving to 6/12 and normal anterior segment findings in the right eye with the normal color and pattern of the iris and normal round regular reacting pupil with nuclear sclerosis of grade 1 to 2. Fundus is within normal limits with normal intraocular pressure. Coming to left eye vision is 6/60 with -5 diopters improving to 6/36. There is 2 mm of lag of thalmus, misdirected and sticky eyelashes, interned and straightened of the lid margins is seen. Conjunctiva is congested with chemosis. In the cornea there are superficial punctate keratitis and it is FS positive. Normal anterior chamber depth with the normal color of iris and pattern, round regular reacting pupil with NS grade 2 and posterior subcapsular opacity with fundus normal, with normal intraocular pressure. Coming to palpebral fissure height in the right eye is 10 mm, MRT1 5 mm, MRT2 5 mm, HCRT is central and Schimmer's test is 35 millimeters of HG. Coming to the left eye, PFH is 13 mm, MRT1 is 5 mm, MRT2 is 8 mm and there is 20 degrees of exotropia with vertical displacement of 3 mm and horizontal displacement of 12 mm. And these are the extraocular movements where there is a restriction in the right eye, dextro elevation, dextro depression and on adduction. And this is depicting the same. There is a restriction of movements of the left eye in adduction. On palpation and firm mass with periorbital fullness medially causing bulge in conjunctiva and caruncle is seen. There is no local rise in temperature, no tenderness of crepitus, no pulsations, no bone irregularities, and on left eye force reduction test it is negative. On auscultation no audible bruit is seen. And this is the CT section, axial and coronal sections of the CT showing heterogeneous mass noted in the medial rectus muscle with proptosis and exodeviation of the left eye. And MRI showing the hyperintense lesions in the extracoronal compartment of the left orbit in the medial aspect causing displacement of the globe outwards and laterally. You can see a fusiform enlargement of the mass in the medial rectus in the third and fourth and fifth photographs. And a provisional diagnosis of left orbit space occupying lesion involving the medial rectus muscle is made. On investigations, left eye B scan, there is normal findings and thyroid function tests are normal. An incisional biopsy with subconjunctival orbitotomy came out to be a HP report of myofibroblast spindle cell proliferation within loosely arranged myxoid stroma showing spindle stellate cells. Inflammatory cell infiltrate consisting of lymphocytes are also seen, possibly or suggestive of a myxoma. The management primary modality is surgical excision of the myxoma, but patient deemed the surgical excision, so next best modality of the treatment is radiation therapy. An intensity modulated radiotherapy as adaptive therapy given to the patient with a dose of 44 grams in 22 fractions over a period of 8 weeks. And this is a pre-radiotherapy photo, and after radiotherapy the patient has improved partially but not completely. And based on the CT findings done 1 year ago, the measurement of 3.7 into 2 into 2.1 centimeter has come down now to 1.7 into 3.6 centimeters. So these are my differential diagnosis of the space occupying benign lesions. And on discussion, before confirming a diagnosis of myxoma, any myxomatous tumor should have a thorough histological examination and imaging to know the extent and spread of the tumor. So far, only few cases of myxoma of the orbit have been reported. Intramuscular orbital myxomas are exceedingly rare entities. Although they are considerably benign, myxoma demonstrate high recurrence rates. This report a unique case of an orbital myxoma involving medial rectus with partial response to radiotherapy. And these are my case reports and references. Thank you.
I guess it would be really difficult to excise a tumor which is within the muscle belly, because in that case you'll be subjecting the muscle to total excision and the eye will go into exo. Secondly, your radiotherapy findings after the radiological findings, it was like 1.7 into 3.6, which it was hardly, the dimensions were changed. They wrote first 1.7 then 3.6 rather than 3.7 first. So there was hardly change in I guess the dimension of the tumor. Anyways, thank you. Can we have the next speaker?
Yeah, and
one more comment Dr. Anusuya wants to say.
Lahari. Yeah.
Yes.
Lahari, so nicely managed case. Why did you say it is partial response? So with radiotherapy, it is not always they shrink. What we look at is that there shouldn't be any progress from there. So you need to look into, and when you did, you talked about this incision biopsy. Was it an attempt to debulk the tumor?
Just for HPE, like just to know the histological
Okay, so
Diagnostic biopsy.
yeah, myxomas are locally infiltrative, but the problem with them is recurrence. So
Yes,
we need to follow up the patient closely.
Yes, ma'am.
Thank
So
you.
what probably Dr. Anusuya wants to say is, in that case, when you can't excise, when your radiations are not giving you good response, at least you could debulk the tumor nicely, so that at least the patient would have lesser proptosis and